right, everyone. My name is Rachel Taylor, and we're just going to go ahead and do a quick video audio check before we get started. So let me know in the chat if you can hear and see me okay. I have one person saying they can't see anything on their screen. Typically, that's a Zoom setting that you have on your end. So what I would recommend doing is logging off and then log back on if for some reason you're having visibility issues. But it looks like you're able to hear and see now. It looks like things are working amazing. All right, we are just about ready to get started. All right, everything's perfect. Amazing. Welcome in. All right, we've got just 30 more seconds. Grab your coffee. I know I have mine, and we'll get started in just a moment. Yeah, right now you'll probably see my face talking, and then you'll see Farm Guess the Med, and you set a picture of a lady. It's me. Yep. My picture's on the title slide here. That's how our designers made it. But we'll get started in just a few seconds. All right. Well, it is officially time to get started. My name is Rachel Taylor. I'm our Director of Nursing Services here at Archer, and I am super excited to hang out with you all over the next 30 minutes as we go through one of my favorite webinars I get to do, which is Pharmacology Guess the Medication. So first of all, I just want to ask, where is everyone joining from? I love to ask this question because I think it's really cool to see that we have people typically all over the globe. Florida, Canada, Chicago, North Carolina, Ohio, Myrtle Beach, Finland, Michigan, Wisconsin, New York, amazing. I typically am in South Dakota in the US, but today I am working from Minnesota, so kind of traveling a little bit. Tennessee, Taiwan, the UK, amazing. Serbia, Arizona, Jamaica, Pakistan, Maryland. So it's so cool. We have one thing in common, and it's nursing. And it brings us all together. And I love asking that question every time I get to do one of these. But today we're going to focus on the endocrine system. And when I say the endocrine system, are you like, oh, I really love endocrine? Or are you more like, ooh, Rachel, endocrine meds are not my thing. So let me know in the comment, how do you feel on endocrine medications from a 1, not confident at all, to a 10, I could answer any question you gave me correctly. Okay, we're ranging from a 1 to a 6.5 is kind of where everyone's at the moment. Most of you are between a 1 and a 5, though. No one's hitting a 10. 4-ish, 6-ish. Okay. All right, well, let's go ahead. Let's jump right in. Here's our first one. This is a hormone created by our pancreas that controls the amount of glucose in our bloodstream at any given moment. It helps to store glucose in our liver, fat, and muscles. Without this hormone, we can't store glucose in our muscles or liver, and we can't make fat. Instead, without this hormone, the fat breaks down ketone bodies and causes our blood pH to drop to dangerous levels, leading to DKA. So, what might we be talking about here? And several of you are getting this one correct. So, really good job. Amazing. But yeah, most of you are asking, hey, what is insulin? And when we think about insulin, it's a peptide hormone. It's produced by the beta cells of the pancreas. And those are going to play really that central role in regulating our blood glucose levels. And what it does is it enables those cells, particularly in the muscle, the fat, and the liver tissue, to really absorb that glucose from the bloodstream and use it for energy or store it as what is called. Does anyone know how we store glucose, what it's called when we store it? Anyone remember that name? Glycogen. You got it. Nice job. So glycogen is how we would store glucose. And so what happens is insulin also promotes like fat and protein synthesis. So when we inhibit the breakdown of stored energy sources, what happens is insulin production is insufficient, or when that body becomes resistant to its effects, the blood glucose level is going to what? If insulin's not working, if the body's resistant to insulin, what does glucose do? It goes up and up and up. And that's where we see that diabetes mellitus, right? All right. This type of insulin is the only type that can be given via IV push or IV infusion. Let's see how we do on this one. Nice. Yes. So I worked primarily in the intensive care unit, but we took a lot of DKA patients, HHNS patients. We just had a lot of them. But you are correct. But let's talk a little bit about something here that we offer at Archer. At Archer, we have a pharmacology crash course. So if you're like, Rachel, pharm is not my thing. If pharm is something that you maybe struggle with, we have a 10-hour pharm crash course. If you've ever attended our 3-day live review, it's very similar, but it's for pharm across 5 days, 2 hours every night. The reason we added this in was pharm was one of the things we get the biggest requests for every single month because it's one of the hardest things that you can experience. And so because of that, we added this pharm crash course. We have one coming up in just a few weeks. It's $75 to join, but if you're at all interested or like, hey, I need some extra help in pharm, you can scan this QR code to register. Okay. So if you said regular insulin, you were correct. Now, does anyone know what type of acting insulin is regular insulin? Is it rapid? Is it short, intermediate? Anyone know what type? Good. Yes, you guys are getting it right. It is a short acting form of insulin. And what it's going to do is it's really going to start working about 30 minutes after that injection, and it's going to peak within 2 to 4 hours. Why do I care about the peak times? Why does that matter to me as a nurse? So when my insulin is at its peak, what's my blood glucose doing? My blood glucose is going to be at its trough. And when it's at its trough, what is the most likely thing to happen? And you guys have all put it in the chat, a hypoglycemic reaction. And so to prevent this hypoglycemic reaction, what do I need to make sure that my patient does when they are at their peak of their insulin? We probably want them to do what? To have a snack, consume something so that their glucose level isn't dropping too fast. And typically our regular insulin is going to last anywhere from 5 to 8 hours, anywhere kind of in that range. Now, one thing I want to point out with regular insulin, if I'm giving a regular insulin drip because they're in DKA, let's say their blood glucose was 500, is there ever a point I would add sugar into what I'm giving through their drip? Is there ever a point I would start giving dextrose? And why might I do that? Is there ever a point I might give dextrose? So I might give dextrose even when they're on a regular insulin drip, when their blood glucose starts dropping. Now, every facility I've worked at has had different ranges for when that starts, but most commonly it will start anywhere from 250 to 350 because what we don't want to do is we don't want to drop their blood glucose too quickly. So then we'll give dextrose 10% to just make sure that we don't drop it too fast and that our patient is able to adjust because does our body, do our cells, do our brain, does our brain, I should say, does it like a quick change or does it like a slow change whenever we're adjusting levels? Slow. It doesn't like these things to happen fast. And that's why we're going to have to watch it really, really closely. Okay. This medication works by lowering levels of glucose in the blood. This is a fast-acting insulin. It starts to work in about 15 minutes after injection and peaks in an hour. Let's see if we can get this one. If I said your name wrong, let me know. Yes, you got it. And Melissa, good job. Okay. Ezra, good job. Branham, Sammy. All right. Give you guys a moment to put your answer in. All right. If you said, what is Lispro or insulin Lispro, you are correct. So this is rapid acting, like we just talked about. And again, when we think about it being rapid acting, does that matter with our meals? I want us to think about this for just a minute. Do I care about rapid acting insulin and mealtime delivery? Absolutely, yes. It is so, so important. This is typically going to start working within 10 to 15 minutes. So if I don't have meal trays up yet, if I don't have food to give my patient, am I going to be giving their Lispro? Uh-uh. We're going to wait until we have that ready, okay? Because we want to make sure that they are eating really soon after they've been given this Lispro. And it peaks at just about an hour and it lasts anywhere from 3 to 5 hours. So really it should be given immediately before or shortly after meals. And what it does is it really closely mimics kind of that normal physiologic insulin release. And it enables that kind of rapid glucose uptake into the cells. And it's going to help with that kind of post-meal hyperglycemia that would happen. What this does by giving rapid acting, it actually helps our overall glycemic control, which is really important in a diabetic. All right, here's our next one. This is a medication used to treat diabetes. We've kind of been on all of these. This is categorized as an intermediate type of the med and has an onset of 1 to 3 hours with a peak of 4 to 8. Really good job. Yes, you guys are getting it. Good job, Kate. Good job, Fanny. Ashley, nice. Ooh, a few of you are mixed on what your answer is. If you said NPH, which is neutral protamine hagedorn, I want to make sure I say that right. NPH is kind of what we say as nurses. I've never said the full name except for very few cases when I'm educating. But this is that intermediate type of insulin. Now, can I mix NPH? Is this a type that I could mix at all? Yeah, we can mix it. Typically, what type of insulin do we mix it with? Regular. Good. Absolutely. And it's going to work within about 1 to 2 hours after injection. It peaks between 4 and 12 hours. So it has a really long peak, which can be a little challenging. And then it works anywhere from 12 to 18 hours. What it has is it has protamine in it. And what the protamine actually does, so that P and NPH, is it actually is going to slow that absorption. And that's why it works for such a long time. And then most of the time, NPH is just going to be given once or maybe up to twice a day, but typically it's going to be in combo with a rapid or short acting insulin. All right, here's our next one. This medication is a man-made form of the hormone insulin that works by lowering levels of glucose in the blood. This specific type of insulin is a long-acting form, hint, 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 that starts to work several hours after injection and keeps working evenly for 24 hours. This med is used for type 1 or type 2 diabetics. There we go. Now I'm seeing a lot more people get this one right. Good job. This is kind of where that glargine comes into kind of in at this moment. Some people guess this for NPH. The difference is glargine works over how long of a period? Or long acting works over how long? 24 hours. Does it ever peak? No, it never peaks, which means if I have a patient in the ICU or in a PCU unit and they are having their NPO, can I still give them their long-acting insulin? Their NPO, would I still give their long-acting insulin? They're sick. They're in the ICU, the PCU. Ooh, we're mixed on this one, guys. We got to talk about it. Okay. So let's think about this for just a moment. It never peaks, right? It's just going to be steady state for those 24 hours when they've had their glargine. Okay. So if we are at steady state over those 24 hours, and what happens to our glucose control when we're under a stress environment? When we're super sick, we're in a hospital, what happens to our blood glucose in a stress environment? It goes up. because when we have high levels of steroid or when we have high levels of stress, our ability to produce insulin decreases, which means our blood glucose will typically increase. So most often, now we will always check the blood glucose before we do this, but most often, even in NPO patients, we will still be giving their long-acting insulin. Does that make sense? Everyone good with that? If you're not, you can use that like raise your hand or whatever function. Okay, looks like we're good. Now, oftentimes I get asked, hey, Rachel, do I need to memorize everything in the onset, peak, and duration? What I have always done is I've always just remembered the table. Like, what order does the table go in? And then I just know it gets a little longer and I know the beginning and the end. That's how I've always done it. I have never memorized every single number on this chart. Typically what I have done is I know rapid acting, 15 minutes, short acting is 30, intermediate is going to take 1 to 4, long acting 2 to 4. And then I know those peak times, right? But really what I want you to think of is I want you to think of, you know, what would they ask me on for this? What would I need to understand if I'm giving this to a patient? Those are some questions that can help you with what matters and what doesn't, because a lot of times it gets really easy in nursing school to just memorize. Can anyone relate to that? Where you feel like, yeah, I've just memorized occasionally. Anyone done that before? Especially in like pharm, I feel like it's one of those courses where you feel like you have to memorize a lot. The problem I see is once you get to practice, it's like, well, I memorized this, but now something's just a little off, and then you don't know how to apply it. And so we definitely want to work on, well, what matters and what doesn't. What is a distractor and what is super important for you to know when you get to practice? And that's what we work on here at Archer. We want to make sure you have what you need for your NCLEX and you have what you need to be successful. Starting off as a new grad, which we don't expect you to know everything, but there are definitely topics that you want to make sure that you have robust knowledge on. And insulin is one of those. So next we're going to talk about storing insulin. And when we store insulin, really, really important that we keep it away from heat and direct sunlight. So I'm going to give you an example of how if I just memorize heat, direct sunlight, and never freeze, how I could actually get a question incorrect. What if it said I should put my insulin in the windowsill? Well, if I just remember direct sunlight, would I necessarily realize, oh, a windowsill is in direct sunlight? So I definitely don't want it to be in the windowsill. Now, someone asked, hey, is this webinar recorded? It is absolutely recorded. It gets posted to our Facebook and to our YouTube channel. So the other thing is we never want to freeze insulin. So the thing that they could ask you on is, well, we can store insulin in the back of the fridge. Is that a true or false statement? Should I store insulin in the back of the fridge? What do we think? It's not in a freezer. What do you guys think? Can I store insulin in the back of the fridge? Good job, Melissa. Melissa's like, no, we don't want to do that. Jojo said no. Shai said no. Here's why. What happens in the back of the fridge? In the back of the fridge, items are more likely to freeze. I just had it happen, guys, with lettuce. I had lettuce in my fridge. I had it toward the back and it was all hard as a rock and frozen. I'm like, well, that was not ideal, but it's more likely to get cold in the back of your fridge. So we actually want it toward the front or in the side door. And so those are some questions where if you have just memorized, the application piece becomes much more challenging. Okay. And then on average, and you're like, hey, my fridge doesn't do that. And that's true. Maybe yours doesn't, but the chance of it happening to someone is high because everyone has a different fridge, that we actually want to educate to our patients to not put it in the back of the fridge because the risk is higher. And insulin is what? Like, can I go replace insulin for $5? Did I just waste $5 if my insulin just froze? No, it is hundreds of dollars in the US. Every country I know is different on this, but in the United States, insulin is expensive. And so it is a huge waste if it ends up being frozen. And some people don't have the extra funds to replace that insulin. Typically, when I took care of people in DKA, they were in DKA because one, no one ever taught them how to manage their insulin. They were young, maybe 18 years old. Or two, the other thing, they couldn't afford it. They just could not afford it. So they would come in the hospital in DKA and they're like, I just can't afford it. And if that's the case, what do I make sure I do as the nurse? If they come in, no one's ever helped them manage their diabetes. Maybe mom used to handle it. Now mom's out of the picture, or they can't afford it. What do I need to do? I need to get a social worker involved so that we have resources and education happening. So, yes, a diabetes educator is huge. A lot of hospitals now even employ a nurse to be a diabetic nurse educator because there's so many people who just don't know how to manage diabetes. And typically, a bad outcome for a diabetic comes from what? Poor management, right? A lot of times we can prevent those poor outcomes if we have good management of that diabetes. Now, typically, I just remember that, hey, at room temp, that glucose, it's good for 1 month, is like how I like to remember it. So, next we have mixing insulin. So, when we mix it, this is what I like to remember. And my writing with this pen isn't the most beautiful, so hopefully you can tell what I'm writing. I like to remember Nancy Reagan, RN. This is how I was taught this in nursing school years and years ago, but it helps you to remember, how do I inject the air? So what we would do is we'd have our syringe, and normally when I'm not traveling, I actually have a syringe with me and a little demo insulin. But what we would do is let's say we had 10 units. We would draw up 10 units in our syringe, and it's going to be 5 units of each. We would put 5 units of air in the NPH, 5 units of air in the regular. Then I flip up the regular, draw out 5 units, then get it in the NPH, draw out the other 5 units. My insulin is mixed, and then I'm ready to give it. I'm going to be honest. Do you think in the ICU I do a whole lot of mixing of insulin? Do you think it's something I needed to do a lot? No. They would just have insulin pins most often. Where I have seen mixing insulin be way more common, long-term care. So I also took care of veterans for quite a while. And when I took care of them, we always mixed insulin. They did not get insulin pens. The insurance typically didn't cover it. So we would do a lot more mixing of insulin. But the NCLEX loves to test on it. It is definitely a hot topic for your exam. And you're all right. It's going to be clear, cloudy. So when we do the air, though, it's what way? Which one of these is cloudy? Is NPH cloudy or is regular cloudy? NPH. Why? NPH is a suspension. That's why it's cloudy. That's why with NPH, we roll the vial. We don't shake it. We roll the vial. NPH is one that should really only be cloudy. Regular should not be cloudy. We don't need to necessarily roll regular insulin. Why? Because it's not a suspension. Very good job. So then when we talk about giving insulin, what are some of the need to knows? What are some things that you're like, okay, I have to make sure when I give insulin, I want you to think about the sites you might give it, what you need to make sure of. What are some instructions you might keep in mind when you're thinking about insulin administration? So for example, one is we rotate sites. Well, why do we do site rotation? What happens if I don't do site rotation? Well, if we don't do site rotation, we end up with what's called lipodystrophy. And lipodystrophy is where that tissue gets really, really thick. The problem is when the tissue gets thick, it no longer can actually absorb that medication correctly. And now the body can't use it right. It's kind of like, okay, think of it like this. Let's say we're going to inject water into a sponge, and I were going to inject water into a basketball. Okay, a basketball is really leathery and hard. Which one is the water going to disperse in evenly? The sponge or the basketball? The sponge, right? It's when that tissue gets really, really thick that it can't disperse how it's supposed to. And so that's why we care about that so much. The other thing is we really want kind of those fatty areas. So the back of the arm is a good one where people typically have a little fat right there. Around the belly button is good, but what do we need to make sure of if we're going around the umbilicus? What do I need to really make sure of? Okay, someone said that there's fat there. There's a specific distance I need to be from the umbilicus. Anyone know what that is? Yeah, we typically want to be at least 2 finger widths away from that belly button. Really good job. Typically, they're going to say at least like 2 inches away from the belly button is the number. Not 2 centimeters, 2 inches, just to make sure you have that right. The other thing is we can give it in the back and the buttock. I'll be honest, I very rarely give insulin in the buttock. Why do you guys think that is? Why is that not a common place that I'm going to give insulin? Because we're also not to expose our client more than we need to. So it's really not the best place because they would have to get up. We'd have to further expose them. So a lot of times I'm going to use the thigh, the lower part of the abdomen, and the back of the arm. It's really the most common. And just to remind you all of that farm crash course, who here is taking their NCLEX by the end of August or maybe early September? Anyone in that boat right now about to take it? Ooh, several of you are like, yes, that's me. Ooh, Alexis is tomorrow. Good luck to you, Alexis. We're rooting for you. So if you haven't taken it yet, but you're going to at the end of the month, early September, how do you feel on farm? Are you like, hey, I got it, Rachel. I got all of farm down. I feel really confident. If you don't and you need a little more help, you really want to know, here's the key things I need to know as a new grad. Here's what I need for my NCLEX. Scan the QR code. If you're good in it, don't worry about it. But if you need further help, I would really scan the QR code to see what Archer Review has to offer to get you that farm help that you're maybe looking for. For me personally, I felt like when I graduated, I needed to, be perfect in farm. And that's not the case. But I also felt like I didn't have what I needed to be successful in the NCLEX and even get to that new grad period. And so what I found was, okay, I need to learn what I need to for NCLEX. But what helped me the most was also starting practice. And once you start practice, you get used to what do you need for your floor and your unit that you're on. But the NCLEX can be a little overwhelming because it can test you on any med. And sometimes they pick the most random medications. Now, there are a few of you who are testing tomorrow. So I do want to say this before we move on to our next guess what I'm asking about. But if you're testing, here's what I want you to know. I want you to plan for 150 questions. Don't plan for 85, plan for 150. Take a break at question 86 and 115. Remind yourself that you are capable, you are worthy, that you can do this. You have the knowledge. You would have never made it this far if you couldn't. But I also want you to remind yourself that it is okay to not be perfect, that it is okay to not know everything that you might see come up on your NCLEX exam. And you're maybe thinking, wait, what, Rachel? I've spent months studying for this. What do you mean I'm not going to know every topic I might see? Guys, I've been an NCLEX coach for close to 6 years. If I were to go take the NCLEX tomorrow, there would probably be a topic that I did not know. Okay. And if there's a topic that I didn't know, that's okay. They want to see, how do you answer a question despite maybe not knowing the topic? Can you apply that clinical judgment and the nurse knowledge that you have gained over the last several years? Choose your answer, trust your instinct, and move on. No one's expecting perfection from you. And I'm not sure what you mean by what if we already purchased the program. Let me know what question you're asking. Our farm crash course is separate from like our SurePass or our QBank is a separate offering. So totally okay if you've already made a purchase of something else. All right, sweating, feeling fatigued, dizzy, feeling hungry, shaky, tingling lips, confusion, palpitations. What medical emergency do we think is going on? Brenda, I'm not sure I'm understanding your question. Is doing the minimum if 85 questions really work? I always tell students to plan for 150 questions. Never plan for the minimum of 85 on your NCLEX. And if it shuts off before then, it's okay. Yes, you can do up to 85 a day. Sometimes practicing 150, like with our exit exam, is wise because you also want to build that testing stamina. And you should always be doing those questions in kind of one sitting. All right, really good job. You guys got it. Hypoglycemia was our correct answer. Really good job on that one. Okay, we have time for one more. We're going to move over to this one. This medication is a biguanide used in clients with type 2 diabetes. The medication works in 3 ways. It makes the body more sensitive to insulin, decreases the absorption of sugar through the intestine, and it lowers sugar production by the liver. Good. Absolutely. You guys got it. Nice work. So our answer here is, what is metformin? So really good job. Here we're talking about metformin. So let's look a little bit at biguanides. And metformin is an example. So this is going to be used for type 2 diabetics. Can I give metformin to a type 1 diabetic? No. And here's why. When you think of diabetes, type 1 diabetics, it's like the factory is closed. It's not working at all. In type 2 diabetics, the factory is still working. It's just not very productive. And what it's pushing out is not a good product. And so the metformin can come in and it's kind of like your manager, and it kind of gets the factory working a little bit better. Okay. So that's what metformin is going to do. The big thing with metformin, it does have a lot of GI side effects. And so we want to let patients know about that. It can be challenging on the kidneys. We really don't want them having alcohol with metformin. And if they're having a procedure, we always hold it for at least 48 hours. So my dad takes metformin. He is a pre-diabetic. He's not diabetic yet. He loves carbs. So he has not cut them out as at the level that he probably should. He loves carbs. He's like, I don't eat a lot of sugar. I'm like, yes, Dad, but you're eating carbs, and carbs convert to sugar. And so he takes metformin every day. But sometimes he's like, oh, I don't feel very good from it, so he'll skip it. What would we want a patient to do? Do we want them to skip it, or do we want them to be consistent in taking it and then make sure they're communicating with their physician? Yeah, typically we're going to say, hey, we want you to be consistent, but if you are having problems where the side effects are getting too much, you feel like uncomfortable or like you're not feeling very good, let us know, because then what we can do is we can look at, hey, is there an alternative medication? That communication to the healthcare team is so important, and patients don't always feel like they have that. So we want to make sure that we are advocating for them of when to communicate, how to communicate, and what the best kind of way to communicate is. So I just want to remind you, Archer Review, we are here across the nursing lifespan. So whether you're still in nursing school, anyone still in nursing school, I think most of you are testing, but anyone still in nursing school that's here today or about to start nursing school? Okay, doesn't look like it. Taking the NCLEX, going back for your nurse practitioner. We also have CCRN, CRNA. All the things here are at Archer, but we do just want to remind you that we're here for you across the lifespan, and that we are an extra resource here for you. And so if you need anything, reach out, email us. We want you to reach your goals, and I want you to know that you are not alone in this, and that Archer Review, we have your back. Someone asked a great question that I want to answer. Prediabetes patients too are put on insulin. Was not aware of that. Metformin is not an insulin. Metformin is an oral medication that helps make our insulin a little more effective and our glucose lower. And so typically we'll put a pre-diabetic patient on like things like metformin. The goal is that they don't end up becoming a diabetic and they have strong control before they actually would need the insulin. Now, I told you guys, for example, my dad, he loves carbs. He does get a lot of exercise in, but he loves carbs. And so if he doesn't get control of his diet and nutrition, what's going to end up happening? Eventually, he will probably need insulin. The difference, though, is type 2 diabetics, they are not insulin dependent. That is type 1 diabetics. Type 2 diabetics, they can have control through diet and exercise with compliance. But if they're not compliant, hence my dad and his carbs, if they're not super compliant, then a lot of times they do need insulin added in. Are there any questions I can answer before we hop off for today? Was today helpful? Was this webinar content something that benefited you? Let us know what else you maybe would like to see. Would love to make sure I bring that back to the team. Amazing. Looks like it was helpful. NCLEX will always test you on generic names, not on trade names. You won't see the trade name at all. It'll just give you the generic name. All right, everybody. I hope you have an amazing Monday and a great week ahead. We're rooting for each and every one of you, and we wish you the best of luck wherever you're at in your nursing journey. Bye, everyone.